So now we are going to go on to the next topic, which is something that I have been talking about a lot, and I've been using this term, but I haven't told you more details about it. Yes. So what is that topic? So that is induction of labor. So पहले तो मुझे बताओ, do you understand when I told you what is the difference between induction and augmentation? So induction means the process of labor hasn't started and you are going to initiate it. Yes, so you will start the process of labor. Yes, so now the first thing is that you should know what are contraindications for induction. And let me see if you can tell me some concept, because if you just end up mugging up or learning, it will become very difficult. So what is the concept that we should know about contraindications? So all those places where vaginal delivery is not possible. So if vaginal delivery is not possible, can you do induction of labor? No. Yes. So contraindications of induction will also become what? They will also become indications for what? Can you tell me? For cesarean. Yes. So all these patients where you cannot do an induction, you will have to do a cesarean. So it's very simple. एक चीज याद कर लोगे तो दूसरी automatically आ जाती है. Yes. So all contraindications for induction become indications for cesarean section. So can you tell me some of the contraindications, those especially the ones which I've already covered somewhere or the other? So if you remember, cord prolapse. So all the obstetric emergencies where we cannot wait for vaginal delivery, like cord prolapse, like vasa previa, yes, like placenta previa. So in these conditions, you cannot do an induction. You will have to deliver the patient by a CS. What else? So अभी थोड़ी देर पहले मैंने आपको बताया था transverse lie. I told you what? That vaginal delivery is not possible with transverse lie. We also do not do induction with breech presentation. So in general, what we mean is, yes, malpresentations, right? So whenever there are malpresentations, we don't do induction of labor. Very important, active genital herpes. So what is the problem? If my patient has active genital herpetic lesions, if we do a vaginal delivery, there will be a transmission to the baby. Yes, so we will not do this, right? So active genital herpes. Absolutely yes, very good. So a pelvis which is very small, what term will we give it? Contracted pelvis. Then, yes, so twin delivery where we have already written, yes. So twins may, whenever it is a non-vertex first twin, right? So twins may, we have already written non-vertex first twin or monoamniotic twin or conjoint twin. Yes. So these are things that we can sort of do what? We cannot do induction. No. So we don't do it in breech, because in breech the preferred mode of delivery is always cesarean section. We don't do a vaginal delivery for breech. The preferred mode of delivery is vaginal. Is cesarean. Agar vaginal karna bhi hai, if you are willing to take all the risk, then also we don't do induction. She has to go in spontaneous labor. So we don't do induction. Okay? Then very, very importantly, if my patient has history of what? History of a classical cesarean. So you remember what is classical? कल बताया था, incision on the upper segment of the uterus. So I told you that classical cesarean is a weak scar. Yes, so it is a weak scar. So once she has undergone a classical cesarean, I will not do a induction because there is no role of vaginal delivery. Because if I allow her vaginal delivery, what will happen? The scar will give way. Okay, so we won't do it for classical cesarean. Then history of rupture uterus. Okay, so we say once a rupture, always a rupture. No role of vaginal delivery here as well, right? Then patients who have cervical cancer. Yes, so patients who have cervical cancer. Yes, again, once it is cervical cancer with pregnancy, no role of vaginal delivery. We will deliver them by a cesarean section. Yes, so these are important indications that you should know when it comes to contraindications for induction or indications for cesarean section. Okay, is that clear to everyone? Also, when we talk about induction, अभी मैं fetal monitoring पढ़ाऊंगी. Yes, और उसमें मैं आपको स्पेशली बताऊंगी something which is called as category 3 fetal heart rate. Right, so category 3 fetal heart rate is a very bad finding in the baby and it can lead to impending death. So if it is a category 3 FHR, again we will have to do a immediate cesarean. Yes, so then we will have to do a immediate cesarean. So that's what I am telling Sakshi. Fetal distress बहुत तरह तरह का होता है. Yes, so we have to see what type of fetal distress are we talking about. So especially when we talk about fetal distress, we will talk about category 3 FHR, which I'll tell you what it is. Okay. So these are in general indications for cesarean, or as I said, contraindications for induction. Okay. Now, once we understand this, we have to talk about अरे बाबा फेनिल, वाई टॉक अबाउट सम रेयर थिंग्स. पहले तो बोल रहे हो फाइब्रॉइड, ठीक है. सो चलो अगर फाइब्रॉइड हो भी गया तो तुम बोल रहे हो फाइब्रॉइड इन दी सर्विक्स. इज इट अ कॉमन प्लेस फॉर फाइब्रॉइड टू हैपन? नहीं ना बेटा. सो प्लीज रिमेंबर, don't talk about rare things, talk about common and things which come with logic. This is what we want to hear from you in the exams also. We don't want to hear fibroid in the cervix. Of course, that is an obstruction in the path. How will delivery happen? But why go into uncommon, rare things? Yes, so इसीलिए ना फिर वाइवा में आप लोग फंस जाते हो. So when you speak of uncommon, rare things, the examiners, they get irritated and they'll ask you bad questions. So always speak logical, easy, common things first, ताकि एग्जामिनर को लगे कि आपने रटा नहीं है, आपने समझा है. ओके, यस, ओके. सो Shraddha, definitely, but once you do an ECV, it's no longer a transverse lie. Yes, so it becomes a cephalic. So it's no longer transverse, है ना. So हम बोल रहे हैं अगर वो transverse ही है, then you can't do induction. Okay. Now, of course, in heart disease, I told you, you can do induction. कितना बड़ा बड़ा लिखवाया था मैंने. Yes, you can do induction, but what you prefer is what? Spontaneous labor. ठीक है? चलो. Now, once we have decided that we have to do induction of labor, what is the next thing we will do? So the next thing that we do is look at a score of your patient which is called as Bishop's score. Okay, so this is called as Bishop's score. So what is Bishop's score? It is a pre-induction score of the patient. Okay, so it is a pre-induction score of the patient, and this score is a table for you which is there in your concept books also. So I'll show it to you here. So this is the pre-induction score that I was talking about. Okay, so this is what is called as Bishop's score. So the first thing that you have to know is what are the components of a Bishop's score, right? So as you can see, there are 5 components of Bishop's score. There is a cervical dilatation, there is position of the cervix, effacement, station, and consistency. So you must know what are the 5 components of Bishop's score. So then you should know out of these 5 components, which is the most important component? Cervical dilatation, right? So most important for success of induction is cervical dilatation. Which is the least important one? Effacement. Okay, so the least important one is position of the cervix, right? Whether the cervix is anterior or posterior or midline. So least important is position of the cervix. Yes. So when we talk about a Bishop's score, we give these marks to every finding and we will add it. So if the total score is more than or equal to 6, we call it as favorable. And the scoring is out of how much? It is out of 13, right? So if the score out of 13 is more than or equal to 6, we call it as favorable. Okay. Whereas if it is less than 6, we say it is unfavorable, right? Now what you have to know is what are we going to do if it is favorable or if it is unfavorable. But before I tell you what do we do next, there are 2 other terms that you should know. So this is Bishop's. We want to know from you what is modified Bishop's. So modified Bishop's score may only one parameter changes, the rest are same. So effacement is replaced by cervical length. Okay, so effacement is replaced by cervical length. The other 4 parameters are same. So that is what is called as modified Bishop's. Okay, then there is an entity which is also called as simplified Bishop's. Simplified Bishop's will have actually only 3 parameters. They are cervical dilatation, cervical effacement, and station of head. Okay, so simplified Bishop's has only 3 parameters: the dilatation of the cervix, effacement of the cervix, and station of the cervix. Okay, is that clear to everyone? Alright, now once we know these 3 terminologies and what are the parameters, the next thing is what are we going to do once we have calculated the score. So if my patient's score is favorable, I am then going to give her oxytocin to induce uterine contractions. Yes. So once the score is favorable, we will give her oxytocin to induce contractions. Station का मतलब होता है बच्चे, where is the head present in the pelvis. Okay. So where is the head present in the pelvis? Okay, that is what is station. We'll talk about station again when we do labor with you. All right. So one method is oxytocin, which is what is most commonly used for induction of uterine contractions. Do you know any other method? Any other method? So other methods to induce contraction. So I know I have talked to you about ARM. Okay. So artificial rupture of membranes. And okay, I'll show you the slide again. Right. So ARM kab hota hai? So how does this help? By the release of prostaglandins. There is also a third method which is called as membrane stripping. Okay, so please remember, membrane stripping is different from rupture of membranes. In membrane stripping, you are detaching fetal membranes from the lower uterine segment. Okay, so you take a finger inside and you run your finger all along the lower uterine segment. So you're basically detaching the membranes from the lower segment. Okay, you're not doing a rupture. So this also causes release of prostaglandins, but it is not as effective as rupture. Okay, so these are the three methods how I can induce contractions. But which is the most commonly used method? Oxytocin. Okay, it is oxytocin. Alright, some of you wanted to see the last slide again, so I'll show it to you. So this was the slide that we were talking about. So bishops, modified bishops and simplified bishops. Know the difference in the three. Know what are the components. What is the most important component and the least important one. Then which is called as favorable and which is called as unfavorable. Okay? Now, so we have done what are we going to do if it is favorable. Now we will talk about what if the score of my patient is unfavorable. So what do I do if the score turns out to be unfavorable? So if the score is unfavorable, Dubin, as I said, the table is already given in your concept books beta, so you don't have to copy it. Okay. So now what do we do if the score is unfavorable, which is less than 6? So now we are going to do something which is called as cervical priming. Yes, it means we are making the cervix ready for the contractions. Only if the cervix is ready can contractions cause dilatation. Yes, so we have to make the cervix ready, and by priming we mean we will cause softening of the cervix. Yes, so how are we going to do the softening? We can use drugs, so pharmacotherapy, or I can use certain mechanical methods. Okay, so I can use mechanical methods or I can use drugs. Now in the mechanical methods, you don't have to know too many details, just the names. So one is called as laminaria tent. Okay, so laminaria tents are osmotic dilators that are made from seaweed. Yes, so you simply put them in the cervix, they imbibe water, they get swollen and they will cause softening of the cervix. Right, so laminaria tent. The second mechanical method is Foley's catheter. So what does the Foley's catheter do? So what we do is we put the Foley's catheter or bulb of the Foley's catheter into the extra amniotic space. Yes, so we usually use a double balloon catheter here, and we put the Foley's catheter bulb in the extra amniotic space, which means outside the membranes, okay, not inside. So outside the membranes, and we fill it with saline. So 30 to 80 ml of saline is what we use to fill the bulb. So again, what will this bulb do? It will cause a stretching of the cervix and its softening, right? So these are the mechanical methods. Most of the times, they will get spontaneously expelled. Agar nahi ho raha hai, then you are supposed to remove them at 12 hours. Okay. So if they are not spontaneously expelled, then you have to remove them at 12 hours. Alright. But do we use mechanical methods very commonly? No. So they are mostly for your exams. What we do is actually pharmacotherapy, right? So we are going to use certain drugs to bring the softening of the cervix. So what are the true drugs that we can use? So we can use PGE1 and we can use PGE2. Okay. What is the name of the drug when we say PGE1? Misoprostol. And what is the name of the drug which is PGE2? Dinoprostone. Okay, so dinoprostone. Now please understand one very important thing. यहाँ ध्यान से पढ़ लो मैंने क्या लिखा है. Dinoprostone. It is not dinoprost. This is a major error which you do in the exams. Dinoprost is another name for PGF2 alpha, which is never ever used for induction of labor. Okay, it is used for postpartum hemorrhage. Okay. So we are never going to do an induction with dinoprost. No cervical priming, nothing is done. Yes, so don't do this mistake. Right? So dinoprost, carboprost, ये सब एक ही बातें हैं. They are just different names. Okay, so they all are PGF2 analogs which we don't use. Okay, now quickly. Misoprostol ka what dose are we going to use when we are doing this induction? We are going to use 25 micrograms. What about dinoproston? 0.5 milligrams. Misoprostol is available as a tablet. This is available as a gel. Okay. What gel is this? Cerviprime. So very commonly you will see it in your labor wards or maternity wards, right? Cerviprime gel. Where do you put misoprostol? You put it pervaginally. Where do you put dinoprost? You can put it intracervical or in the posterior fornix, but never intrauterine. Okay, so we are not going beyond the internal os. We can put it between internal and external os, that is in the cervical canal, but not intrauterine. Okay. How frequently are you going to put the tablets? So misoprostol is put every 4 hourly. Yes. How frequently can you put the gel? 6 hourly. Yes. What is the maximum dose? So we can give 6 tabs for misoprostol and 3 times we can give the gel application. Right? So 3 times I can put the gel and I can put misoprostol 6 times. Yes. Which is more commonly used? Cerviprime gel. Yes. But which is theoretically better? PGE1. Why? Because PGE1 not only will cause softening of the cervix, it can sometimes also initiate uterine contractions. Yes, whereas what would Cervi prime do? It will usually only do softening, right? So it will usually only do the softening. But still, why is misoprostol less commonly used? Because misoprostol needs more monitoring and it can cause something which is called as hyperstimulation. Yes, so once I teach you labor, I will tell you what is hyperstimulation. So as of now, hyperstimulation means too many contractions, which are bad for the baby's health. Okay, so that is why what we use more commonly is the gel. Now once you have put the gel and you have softened, what are you going to do? So after you have done the softening, you will start the oxytocin to initiate uterine contractions, right? We will ask you what should be the time gap between the last dose of the gel and oxytocin. Answer will remain the same, 6 hours, right? So the time gap between the last dose of the gel and oxytocin will be 6 hours. मान लो misoprostol has not initiated the contractions and you want to give oxytocin now, then what should be the time gap between last dose of miso and oxytocin? Again, as I said, the answer remains the same. There has to be a gap of 4 hours to prevent what? Hyperstimulation. Yes. So these are the agents that we use for softening of the cervix. And as we said, once the cervix is softened, it is ready to get dilated. And who will dilate it? The uterine contractions. Yes, so the uterine contractions will now dilate it. So you prepare the cervix so that the contractions are able to dilate. If it is not prepared, it is thick. No matter how many contractions you may give, it will not dilate. Yes. So somebody was asking me, ma'am, why do the priming? Okay, because if the cervix is not ready, bacha, no matter how many contractions you give, it will not dilate. Alright. So these are things that you should know about induction of labor. When not to do it. Once you know you have to do it, what are the methods? What is Bishop's scoring? Is that clear to everyone? Yes? Okay. So now, once we know induction, we also know what? We also know indications of cesarean section. है ना? So now we also know indications of cesarean section in my patient. Now, some of the things when we talk about cesarean section is once you do a cesarean, do you realize that the patient becomes a case of previous CS? Yes. Now before I talk about as a case of previous cesarean, there are some things that you should know about CS by itself. Okay. For example, some very basic things. Okay. You now know the indications for CS. We just wrote it down in the previous part. Okay. And I'm not going to write it again. So they are same as contraindications for induction of labor. ठीक है. So पहली बात तो ये है. दूसरी चीज, there are certain things which can be asked as one-liners. So only these points which can be asked as direct MCQs. Okay. So the first question is, do you give prophylactic antibiotics before doing a cesarean section? Yes or no? Yes. So we will give prophylactic antibiotics before we do a CS. Right? So the MCQ will be, when should you give it? So you should give this 60 minutes before skin incision. Okay? So 60 minutes before the skin incision, we should give prophylactic antibiotics. Yes? Second, do you remember about the position of the patient? Yes? So what are the positions of the patient? So if you remember this, the position which is good for the patient is, I told you, you have to keep her supine, but place a wedge under the right hip. Why? To give her a slight left tilt. Yes? To give her a 15-degree left tilt so as to maintain the uteroplacental circulation. Very good. Okay. My third question is, when you talk about cesarean, and we've already talked, what is the most common anesthesia? So in general, we said that the most common anesthesia we use is spinal. Yes. So with respect to the anesthesia, we also want to ask you, what will be the level of sensory block? Okay. So what is the level of block? So please remember, the level of block is T4. Okay. The level of block is T4. Although the pain sensations from the uterus travel via which nerve roots? So uterus से जो pain sensation जाता है, it travels via T10 to L1 nerve roots, right? So it is given from T10 to L1 nerve root, okay? But if you see, the level of block is much higher. Why? Because you want to block the sensations from the peritoneum. Q? Because you know, during our cesarean, we are going to pull the peritoneum. So it will cause pain to the patient. So you have to ensure that you block the nerve supply from the peritoneum as well. So the level of block is T4. Okay, it is T4. Then, what incision do we use on the uterus? So remember this. If this is the uterus, we will most commonly give this incision. Yes, what is this incision? So it is a lower segment incision. Okay, so this is a lower segment incision and it is a transverse or Phanon-Steel incision. Yes, so the shape is transverse or Phanon-Steel. Now this incision is called as Kerr's incision. Okay, so please remember, this is the uterine incision that I am talking about. Kerr's because it is named after the doctor Munro Kerr, right? So majority of times I am going to give a lower segment incision. Why? Because this has good strength, right? So the healing is good. It is a strong scar. So this is what we give. Okay. On the other hand, what is the other type you know? So the other type I told you, if this is the uterus, I can give this incision. What is this? So this is a vertical incision on the upper segment. Okay, so this is a vertical incision on the upper segment. This is what is called as, I told you what? Classical cesarean. Do we give a classical cesarean these days? The answer is no. So in modern obstetrics, we don't do classical cesareans because they have high risk of rupture. Okay, anywhere between 4 to 10%. So if this woman becomes pregnant again, the scar will rupture. So we don't do this. So classical is not what we use these days. But if I ask you in modern obstetrics, right, what are the indications for classical incision? Okay, so these days the indications for classical are, number one, the best answer is cancer, cervix and pregnancy. So because the lower segment itself is formed by the cervix, I am not going to operate near the malignancy. I am going to operate away from it, right? Then second, you already know I have done with you is PAS, placenta accreta spectrum. No बच्चे, placenta previa में हमेशा lower segment होता है, not upper segment. Okay, PAS में lower segment, upper segment होता है. Okay. Third, if there are dense adhesions, okay, between lower uterine segment and fibroid. Okay, so if there are dense अरे यार तुम जो बोलते हो वही मैं लिखना शुरू कर देती हूँ. So if there are dense adhesions between the lower uterine segment and bladder, right? So if there are dense adhesions between the lower segment and the bladder, तो क्या होगा? To reach the lower segment, you will have to cut these adhesions and then there is a very high risk of bladder injury, right? So इसलिए you better cut on the upper segment. Fourth good answer is repaired vesico-vaginal fistula, right? So a repaired vesico-vaginal fistula. And yes, fifth is something very obvious. For example, you're operating immediately in a post-mortem patient, then you know you will quickly give the incision on the upper segment in order to maybe a probability on saving the life of the baby. But those are not good answers, so they should be kept much lower down. So ये जो सब आप चीजें बोल रहे हो ना, fibroid in the lower segment, ये सब रटे हुए आंसर हैं, ठीक है? मैंने हमेशा बोला पहले रटे हुए आंसर नहीं देने हैं. Yes, if there is obstruction in the lower segment, like fibroid in the lower segment, then you don't want to cut over it. But then, you know, I will tell you, what if the fibroid is in the posterior wall? Then? So it doesn't matter, na? Now you can cut in the lower part. Yes, so the idea is, जहाँ पे काट रहे हो, वहाँ पे there should not be a problem. Yes, so in these cases, I would want to give the upper segment cesarean. Yes, ठीक है बच्चा? Now, coming to, I said we give a fan and steel incision. So, कौन से instrument से देते हैं incision? Scalpel, है ना? So you use a scalpel. So now I want to know from you is, there is no doubt I will give the incision with a scalpel, but what kind of dissection do we do? So हम क्या करते हैं? We make a very small incision in the lower part, and then you don't stretch it with a, you don't cut it with a scissor to extend it. We use blunt dissection to extend the incision. मतलब, if you see in the operating room, हम छोटा सा nick देते हैं and then you put fingers in that nick and you stretch it. Yes, has anybody seen a cesarean section? So yes, so these days we use our fingers to stretch. So this is what is called as a blunt dissection. I am not using a Mayo scissors to cut it. Yes, so any idea on why do we use blunt dissection and why not sharp? So when you cut with scissors on either side, then you call it as a sharp dissection. But I am saying what we do is blunt. So why blunt? Because with blunt dissection, there is less pain. There is less blood loss. There is less need of post-operative analgesia. Right? So, less pain, less blood loss, less need for post-operative analgesia by the patient. So this is why we are nowadays doing blunt dissections and not a sharp dissection. Is this clear? Yes? Yes. So when you use blunt dissection throughout, we call it as a Joel-Cohen technique. Yes? So Joel-Cohen is nothing but when you follow the entire operative procedure with blunt dissection. You only give small incisions and then you use fingers to stretch it. Okay? So these are some of the important things with respect to the incisions. Okay? Now talking about what should be the ideal time gap between uterine incision. Okay, so ideal time gap between uterine incision and delivery of the baby. Anyone? So please understand, I am not talking about time gap between incision on the skin and delivery of the baby. I am talking about incision on the uterus and delivery of the baby. Yes? 30 seconds. No, no, no. We are not robots. Huh? So this has to be 90 seconds. Okay, so ideal time gap between uterine incision and delivery of the baby is 90 seconds. So you should be able to do it within 90 seconds. Okay, don't take longer than that. Okay, the name was Joel-Cohen beta. So blunt dissection का नाम होता है Joel, Joel, Cohen. H is silent, Cohen. Okay, so this is the Joel-Cohen technique for blunt dissection. Okay, then usually in how many layers do you close the uterine incision? In how many layers do you close the uterine incision? So generally we will close in 2 layers. So closure of uterus is generally done in 2 layers, but can also be done as a single layer closure. So basically अगर आपको समझ में आए, the first layer is what is the most important one. The second layer is usually for hemostasis. Okay, so the second layer that we are adding is only to maintain hemostasis. So agar first layer ke baad there is no much bleeding, then it's not necessary to give the second layer. Is that clear? So please remember, second layer is primarily for hemostasis. Right? Yes, is this thing clear? So these are some of the things that you should know with respect to operative procedure of cesarean section. Okay? Now let's say you have operated on this patient. She is happy, she has a baby now and she goes back home. But after 2 years, she comes back to you. Why? She is pregnant again. Yes? And she is coming back to you because you are a good doctor. She wants to show to you only. Yes? You are the best ones in your field. So she comes back to you. What does she become? She becomes a case of previous CS. Right? So she becomes a case of previous cesarean. So is this patient a high risk patient? Yes. So previous cesareans are high risk. Why? Because the scar can rupture. So majority of times when you want to sort of think about what will you do with this patient, what are the kind of questions you get? So there are 2 main questions that you need to answer. So it is, how am I going to deliver her in the current pregnancy? Yes. So which means, am I going to do a repeat elective cesarean section? Yes. Or am I going to do a VBAC. Yes. So repeat elective cesarean matlab no vaginal delivery. She has to be again operated upon. Right? What is VBAC? VBAC is vaginal birth after CS. This is also called as TOLAC. Okay. So this is also called as TOLAC. What is TOLAC? Trial of labor after cesarean. So TOLAC is trial of labor after previous CS. So in the exams, majority of times we want to know from you, what are the conditions where you do a repeat elective cesarean? Yes. And therefore they become what? Contraindication for VBAC. Right? So this is what we will ask you in the exams. कहाँ पे VBAC नहीं करना है, and you have to definitely do a repeat CS. So now this becomes really easy because it's an overlap. If your patient has a previous history of classical cesarean, will you do a vaginal delivery or will you do a CS? So if it is previous classical, no vaginal delivery. Second, if she has a history of rupture uterus, then again no vaginal delivery, she has to be taken up for a repeat cesarean. Third, if she has undergone more than or equal to previous 3 LSCS, right? So अगर उसके 3 बार lower segment cesareans हो चुके हैं, then again no more vaginal delivery. Okay, the uterus is weak and we will do a elective cesarean. Yes. Fourth, if my patient has certain conditions or certain types of scars like myomectomy and hysterotomy. Okay. Myomectomy and hysterotomy. Myomectomy किसकी सर्जरी होती है? It is a surgery for removal of the uterus, removal of the fibroid, right? So myomectomy may not always, but sometimes what happens is the scar goes very deep. So when you are trying to remove the fibroid, you go really deep, and sometimes more than or equal to 3, probably more than or equal to 3 previous LSCS beta. पहले में 3 था, नहीं, it's not silent. I just forgot to write it. More than or equal to previous 3 LSCS. तुम बहुत बदमाश हो, हाँ? Okay. So myomectomy, if it's a deep incision which has gone into uterine cavity. So which means the incision is through and through. बाहर से शुरू हुआ और अंदर पूरा cavity तक पहुंच गया. So it's a full thickness cut. Yes, and if it's a full thickness cut, then it becomes a weak scar. Yes, so previous myomectomy where you have opened up the cavity. Hysterotomy क्या होता है? Opening of the uterus in the second trimester. So sometimes when all your medical and surgical methods of MTP fail, what is the last resort? You have to cut open and remove the products. Yes. So not commonly done, but yes, may be done sometimes when my medical and surgical methods have failed. So then I will have to do a hysterotomy. Yes. Fifth, if my patient has something that is called as cephalopelvic disproportion. Okay, I will do CPD in labor. So abhi ke liye you just have to write that CPD in the current pregnancy. Okay, so CPD is cephalopelvic disproportion. The rest all are indications of CS. So I'm not going to write all of them again. These are things specific to previous cesarean. Right? बाकी सारा list आपको already पता है. So we are not going to write the entire list all over again. The other indications of cesarean, as mentioned before. For example, placenta previa or contracted pelvis, right? So all these anyways become indication for a cesarean section. Okay, beta, is this clear? Oh, in the list of contraindications, did we write about contracted pelvis? So मैंने अभी पढ़ाया नहीं, so maybe I didn't mention it, but did I mention? अगर नहीं किया तो लिख लो please. So where we have written contraindications for IOL. Okay, वहां पे I am saying add contracted pelvis. Okay. Chalo. So these are indications. Okay. So these are indications where we have specially mentioned about what? When patient has undergone one cesarean and I am not doing a vaginal delivery for her. Now if she is pregnant, I will do a repeat cesarean. Okay? What about relative indications? So ये समझोगे क्योंकि ये एम्स वाले पूछते हैं. So relative indications for repeat CS. Okay? What does it mean? It means although I can do a VBAC, but I usually don't do it, I prefer doing a repeat CS because the risks are high. So point number 6 is other indications of CS beta जो आपने पहले लिखे हैं. अगर वो होंगे then obviously you have to do a repeat cesarean. You can't do a VBAC. ठीक है? So repeat cesarean is preferred over VBAC is what we mean by relative indications. ठीक है? इसके बाद I'll give you a short break. Hold on. So repeat इसमें कौन कौन से आते हैं? So number 1, if the baby has macrosomia, if it is a pregnancy where the baby is in breech presentation, and if the pregnancy is post-term, which means gone beyond 42 weeks, right? So in all these conditions, so macrosomia, we're talking about a patient with previous CS. And in the current pregnancy, they have what? Macrosomia, or in the current pregnancy, they have breech, or in the current pregnancy, it is post-term. Okay? So these are relative indications for repeat CS. Okay? Acha. So the only part for this topic left is outcomes of VBAC. We'll quickly do it in 5 minutes and then we'll give you a break and then we go on to the last topic for the day. Okay? So outcome of VBAC क्या हो सकते हैं बताओ? So outcome of VBAC हो सकता है successful vaginal delivery. या फिर the outcome can be what? The outcome can also be what? An emergency CS. Yes. So there is a possibility that the vaginal trial becomes successful and the baby delivers vaginally. Okay. The other probability is that I had to take up the patient for an emergency CS in between her labor. Yes. Now here we ask you, which is the most important prognostic marker for successful VBAC? Okay. So the marker for successful VBAC is previous history of vaginal delivery. Okay. So if patient has undergone a previous vaginal delivery, the chances of successful VBAC become higher. Right? So the chances for successful VBAC become higher if she has a previous history of vaginal delivery. Why would you have to do an emergency cesarean? So this could be because of impending rupture or rupture uterus. Actually, rupture uterus में we don't do a CS, we call it as a emergency laparotomy. Okay, we actually call it as an emergency laparotomy, right? So we want to know from you, what are the signs and symptoms of impending rupture? So impending में सबसे पहले क्या होता है? Okay, come on, focus everyone. Just 5 minutes more for this topic and then I'll give you a break. If you want a break, I can do this part after the break also. Yes? Do you want a break right away? We can do this part after the break also. Okay, so signs and symptoms of impending rupture क्या है? Number 1, if there is evidence of fetal distress. Okay, this is the most common or the first sign or symptom of impending rupture. ठीक है? Second, if there is scar tenderness in my patient. Which tenderness of which scar are we talking about? Abdominal scar or uterine scar? So this is uterine scar. Okay. And third is maternal tachycardia. So if I see during labor, my patient develops fetal distress, or she develops scar tenderness, or there is maternal tachy, then I suspect an impending rupture. Can you tell me which is the most important out of the three? So always the most important is fetal distress. Okay. The other two become important only when they are associated with fetal distress. Otherwise, they are not important because there can be many reasons of maternal tachycardia. Okay. Fetal monitoring. The last topic will be fetal monitoring. So we will quickly do it. Okay. No. So Harshita, we are not interested in abdominal scar tenderness. Okay. Abdomen थोड़ी फट जाएगा. Yes. So we are talking about uterine scar tenderness. Okay. Now when we talk about rupture uterus, what are the signs and symptoms for this? Can you tell me? So the mother will have tachycardia. She may or may not have hypotension. Why? Because what will happen, beta? Samjho meri baat. When the uterus will rupture, there will be intra-abdominal bleeding. Yes. Not only that, the baby will come out of the uterus into the abdominal cavity. Yes. So the baby comes out of the uterus. Yes. So if the bleeding inside the abdomen is much more, then she will have hypotension. So maternal tachycardia, hypotension, she will have vaginal bleeding. Fourth, there will be severe fetal distress. Okay. Not only severe fetal distress, sometimes the fetal heart rate may be absent. Why? I told you because the baby is coming out of the uterus. So it loses its connection with the placenta, right? So it loses its vascular supply. So the baby is going to die. Yes. Then she will complain of generalized abdominal pain. Yes. So she will complain of generalized abdominal pain. The uterine contour, which means the boundary of the uterus, will it be well felt or will it not be well felt? So uterine contour will be lost. So if you try and palpate the boundary of the uterus, you will not be easily able to palpate it because it has ruptured. Yes. And can you tell me what will happen to fetal parts? They become more superficial. They have come out of the uterus into the abdominal cavity. So the parts are more superficially felt. Yes. And if we ask you what is the most specific finding, okay, then this is called as loss of station. So normally क्या होता है, the head of the baby in labor is coming down, 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 down. क्या ऐसा हो सकता है कि वो पहले नीचे आ रहा था और वो suddenly ऊपर चला जाए? नहीं, that is not possible ना. That will only happen when there is a rupture. So what happens is the baby is expelled into the abdomen. It moves upwards. So loss of station means a station which was coming down suddenly goes up. Okay. This is the most specific finding for rupture uterus. It is not seen with any other condition, right? So these are signs and symptoms of rupture. Okay. Beta, hypotension, because she will have intraperitoneal bleeding. Okay. What is the management? I said is emergency laparotomy. Yes. So it is an emergency laparotomy. And what do you do in this? Do you do a hysterectomy or do you try and repair? So if it is a clean rupture, we can repair as well. But if you cannot maintain hemostasis, then I will have to go ahead and do a hysterectomy. Okay, then I will have to do a hysterectomy. No, beta, how will the amniotic sac be intact? The baby is coming out of the uterus. It will obviously break the amniotic sac and come. Yes, so the baby is coming out of the uterus into the abdominal cavity. So this is what is rupture. So please remember, in rupture, all layers of uterus are breaking, including the serosa. So all layers of uterus are rupturing, including the serosa. Is that clear to everyone? Yes? Okay. So this is what you should know. And now I want to ask you, once you understand why previous cesarean is a risk factor, can you use misoprostol? Can you use misoprostol in previous CS? No. I told you the problem with misoprostol is that वो और ज़्यादा contractions कर सकता है of the uterus and the chances of rupture increase. Also, I cannot control. Once the tablet is given, it is given. Oxytocin का फायदा क्या है? That you can stop it any time and it has a very short half-life. So please remember, never give misoprostol to a patient with previous cesarean. Can you give oxytocin? Yes, oxytocin can be given, although that will also increase the risk, but it can still be given. Misoprostol is absolutely contraindicated because I can't control. Once I give the tablet, I can't take it back.